Okay, dope. So today we're going to be talking about COVID rehabilitation. And it's a nice roundup, or it's a a roundup of everything that we've been speaking about within the council for the last quarter. So Josh, the next slide. And between reports and events, we have covered the lived experience of COVID-19 in terms of what it has been like to have the virus, plus its secondary effects and the secondary consequences of those effects. That is in a report format. We've also looked at specifically at the workforce. So what are the changes that have occurred within people working from home, and we're gonna actually go into detail within this workshop. And we've also covered specific elements within the built environment, such as air pollution and how it has affected very specific communities, specifically those that are racialized as Black or racialized as Asian. And so today, all of it is going to come together under one umbrella of basically how the fuck do we get ourselves out of this mess? And we're going to do this in the context of the workforce for three main reasons. One, the workforce going back into work or going back into that normativeness is going to be probably one of our biggest hurdles. Work, as you can see, plays a very key and fundamental role in our health. And three, work and finance, of course, plays a also crucial role in accessing healthcare, and also health in a systemic way. So it is a very important part of coming back, as it were. So that's why we're going to contextualize it in terms of the workforce. But all of these reports are up in the back end, again, for you guys to access. And also, please don't forget about the HPA Access lexicon, or the health lexicon that we have in the background that goes into detail about how the HPA Access works, about why we study it, etc., just so you can start building that lexicon in the background. So when I do go through it in very short detail, you guys know where to find it in the back end, and just get yourself a little bit more orientated. Okay, next slide, please. Okay, so what we're going to cover today is, hopefully I can get through the overview in 15 minutes. Then we're going to do an exercise for 30 minutes, and then we're going to come back and feedback from that exercise in 30 minutes. Next slide. So in total, you're going to be with us for 90 minutes. So let's start where we were at pre-pandemic. Pre-pandemic, we were already at a health crisis, and you know most of these statistics. These aren't new. Centric at the end of 2019, yes, at the end of 2019, we published areas of health emergencies around London using our software system, which at the time we called Urban Health Index. And it was areas identifying of biological inequity, which is also a term that was coined within Centric by our colleague Elahi Hussein, which describes the people that lived in disproportionate amount of stress, both from psychological stressors, but also from environmental stressors. And we were already speaking that it was within these areas and within these communities and within these peoples that health was looking very, very poorly. The poor health outcomes were through the roof. So we already were declaring a health crisis before COVID struck. So you can just imagine where we are now, that COVID has put us in an even worse situation. And if we don't actively start changing things systemically, we are going to create a severe health inequity. And it is from our research that it will be almost the new guise or the new iteration of how discrimination is going to be. It's going to be the people that have health versus the people that have health. Next slide, please. So let's look at the HPA axis, our lovely biological system, from an office worker and the person working from home. As I said, there is an entire report on the secondary effects of COVID and the lived experience of COVID that goes into this in deep detail. So go ahead and read that for further education. So I'm just going to glance over this. So next slide. So I know most of you have seen this before. So the reason the HPA axis, we study it as well, is because it allows us to understand those biological pathways between what is happening in people's lives and their lived experience and the environments that they're living in, and how that connects over to the non-communicable diseases, which are the ones that we are now very worried about because they are heading towards spikes, but also they're really ones that we don't have any cures for, right? We don't have any cures for diabetes. We don't have cures for obesity. We don't have cures for depression, none of them. Where obviously medicine has advanced that for the communicable diseases like malaria or diarrhea or anything like that, there are medicines for that. So this adds that extra layer of urgency that we don't have a way of curing these diseases, but they are spiking at levels that are quite frankly dramatic and concerning. So if we take it in the context of a office worker, the average office worker, what are some of the psychological stressors that they can experience, specifically within the context of this pandemic? Financial worry, if they've been fired or furloughed, contracting COVID, for example, for those who have still had to go to work, the fear of getting COVID, but also the fear of transferring COVID to a loved one, especially if that loved one has an autoimmune disorder or has been categorized as a person that could get COVID and it could be very lethal to them. Living with that worry, living with that anxiety is a psychological stressor that engages the stress response, that leaves you what we call in psychology or cognitive science, rumination. So that's when your thoughts go in a loop. What if, and you start creating different scenarios of anxiety and worry. But also perhaps when you're working at home, very cramped working conditions, uncomfortable working conditions. And then of course, there are the discriminatory factors that a worker, an office worker can experience both inside the building when we were there and also within the context of COVID. And then the physiological, well, those are the same as always: air, noise, light pollution, thermal discomfort. And I added sedentary, although there it says sedentary, sorry, dyslexia. But those are all physiological stressors, which again engage the stress response in the same way that it asks us for an adaptation. What ends up happening, of course, as you have now learned, is that that accumulation or that constant engagement of the stress response causes a multitude of complex deregulations in our system. And by deregulation, I mean that our metabolic, our immune system, our endocrine system, these big systems that keep our body ticking, right? They keep our body doing the things that they need to do at the right time. Our lungs, our heart, our blood, our temperature, all of that is governed by sets of hormones and chemical reactions that are conversations between the brain and our hormone system, which sits on top of our adrenal glands. And when there is a deregulation because we have over asked it for this adaptation, those systems no longer work the way that they should. So our sleep-wake cycle malfunctions, our metabolical systems malfunction, our metabolical systems are part of our economics of our body, how our body understands its energy exchange and when we're supposed to be doing what organ is supposed to be doing at what time. And that's actually what leads to things like obesity. Obesity and diabetes are technically complex metabolical syndrome disorders. And then things like depression and cardiovascular and anxiety are also part of the deregulation of the stress response and of the immune system and the endocrine system. And in the cases of depression and anxiety, we're now seeing that it's also deregulation of our gut, the way that our gut works. And the same thing with PTSD. So once we get to that deregulation, it shows up as disease. That's what disease is. Disease is the manifestation, but it's the last part of that deregulation. Next slide, please. So what I want to look at is that worker health or health in general is systemic. So in this workshop, we're not going to be looking at, yes, meditation is wonderful, so is yoga, so is good nutrition, but we're going to go at a much more systemic view of health rather than focusing on that individual, because unfortunately at the individual there are different levels of access due to economics, and therefore it's not the most equitable way to speak about health. Even though, of course, I encourage everybody to do meditation or organized breathing, as it is technically called, because it is free and we are able to do it at any time that we want to. But again, when you give that recommendation, but someone's living in an area of high levels of air pollution, you can see how that can be almost like a conflict of interest when it comes to health if we don't address the systemic issue. The same thing, if we say you're 5 a day, but that person cannot afford it or doesn't have the infrastructure at home to be able to do and access to 5 meals a day, the 5 fruit and veg day, again, without tackling the systemic, the individual side becomes almost a moot point. Next slide, please. Okay, so let's look at it from, we're going to look at it from 3 different things. The latest report is going to go into more detail. But again, so we're talking about systemic. So the commute. So the commute plays a role in our health in the following ways. It makes us more sedentary. So the longer the commute, the longer time you are sat in one place. Sedentary behavior is more than just gaining weight. It actually is attached to poor digestion. And it's also attached to poor breathing. So you physiologically speaking, you're not able to breathe properly and take deep breaths, which are essential to moving blood through your organs and thus organ function, because blood going into your tissues is what actually helps create the essential organ function. So if you truncate that very first part of the supply chain, taking in a deep breath, then that causes, through time, will begin to cause, again, that deregulation that we're talking about. So sedentary behavior, it's important that we talk about it way above and beyond your gaining weight. It actually truncates, like I said, your breathing pattern, and this starts affecting digestion and a whole bunch of other metabolic functions. So your risk to health is cardiovascular, obesity, anxiety, depression. Then, as I said, the longer the commute, the worse for your health it is. And there again, we're talking systemic and complexity, where yes, it's the time that you're in sedentary position, but it's also the amount of time that you are ingesting noise pollution, air pollution, buses, TFL, car, even bike and walking really do put us in contact with a lot of levels of air pollution. Walking mediates it because you're also doing something physical. So it's a little bit of a mediator, but asking somebody to walk for an hour across a red route is really not the healthiest option for them, even though they are doing physical exercise. So again, looking at it from a systemic lens. And then, but then also you're taking away time from people and creating time poverty, which can be used for self-care, can be used for exercise, could be used to even having the time to prepare a fresh meal, because it's eating out of that time, that commute, and you're also pulling them away from society and their community. So we actually have a couple of sources, really good ones for you guys in the built environment, about how health is very much related to social cohesive neighborhoods. And then of course, the next one is air pollution. Y'all know what the relationship between air pollution and health is, so I'm not going to go into detail from there. All of that, again, leading to the depression, anxiety, cardiovascular disorders, both in between the sedentary, long commute, and air pollution. Next slide. And so now it's time to look at urban footprint. So again, looking at things systemically. So work in life isn't just about the building, right? I.e., like the house that you live in, the building that you work in. And there's a lot of pride in, oh, we're all building has this health standard, this regulatory system, it's this efficient when it comes to its green credentials, et cetera, et cetera. But if that building is located at an intersection that has high levels of noise and air pollution, again, it doesn't matter. The people that are coming to that building or to get to that building or to get to their home, That's the urban footprint, that toing and froing from point A to point B. If that toing and froing has high levels of all those environmental stressors, noise, light, thermal, etc., that is all contributing to that body, to that person having to adapt to all those levels of stressors. So again, it's on our website. We did a story about workers that are working in central London, even in the luxury parts where it's Mayfair, and we think exactly that they what do you call it? They market it as luxury, which is ridiculous because being polluted by all these stressors should not be classified as luxury. And so you have all of these workers working in an incredibly stressful environment, i.e. physiologically stressful, that is constantly asking their bodies to adapt. So again, I'm not going to go into the details, but you can get it in the report of how all these different stressors contribute to non-communicable diseases through the stress response. Okay, next slide. And then these last ones, the low access to green infrastructure and frequent commutes. The one that I really want to go into is the low access to green infrastructure. Again, green has been, do you go to a park and do you sit there, or do you do exercise or whatever? But really what, and also about curtailing air pollution, but green infrastructure is way more than that. He's not here, but Jake Robinson, who we're working with, he's doing amazing groundbreaking research into the microbiome. So the microbiome of nature and how it interacts with the microbiome or our gut. And what his research is unearthing is that from trees, we get specific nutrients that nourish our gut, or conversely, damage our gut in the cases of urban environments. So being around green spaces is an actual part of our nourishment. And that is something that I do want to pass on, that we start thinking of green spaces not as access just to exercise or an aesthetic, but as an access to nourishment. Okay, next slide. And then further into the report, we're also going to look at the work environment and we look at salary as two other macro points of stress or points of support in terms of health. Next slide, please. So now let's get into the pandemic lived experience. Next one. Like I said, there is a whole report that you guys can slowly read in your own time. Again, I'm contextualizing this in terms of the worker. So you have let's say the office worker and the hospitality worker, and then we have the hospital worker, and going across their different experiences within the pandemic. So the office worker, yes, there have been lovely reports about how, look, we are exercising more, we are going to green spaces, spending more time with our family, et cetera, et cetera. But of course, that is a singular factor way of looking at the phenomena rather than systemic. It also has meant, especially for the lower waged office workers, living and working in cramped conditions that are overcrowded, that are noisy, that don't have the ergonomics that is necessary to do good work. There is also the added pressure of constantly feeling that you have to perform so you don't lose your job in a state where many companies have furloughed, many companies have used the excuse of COVID to completely restructure their companies and laying many people off. So people under a lot of duress to keep performing way above and beyond the hours that they're supposed to. But there's also been acute and drastic and quick changes that happen to people's lives, that things like childcare or secondary incomes or things that they have used to sustain their well-being, whether it is yoga classes or neighbors and socialization and family structures that help us stay healthy, just went away from one day to the next. And of course, people also, which goes on to the hospitality worker, which a lot of them have lost their jobs. So that puts that added pressure of finding yourself again almost caught out because you don't have savings, because you didn't prepare yourself for the phenomena of a pandemic that was going to take away your savings or all of a sudden put you in financial pressure that you didn't have before. And then the same thing with hospital workers. Hospital workers we're teasing out because they are, as well as care workers, they are the ones who are going to suffer the acuteness of PTSD and depression. But PTSD is running across all different worker types, all different people, because getting the disease itself has triggered PTSD in many people. It also has triggered anxiety and depression. And I'm talking just of going through COVID alone, not even within the symptomology of COVID. I'm talking about the experience of the disease of COVID, which are two separate pathways. And that is seen in many other diseases. People that go through cancer and chemo do end up, some of them, end up developing depression and anxiety and PTSD because the experience of it is traumatic. So these are, again, next slide. There are more that we're going into in the report. We're looking at factory workers, drivers, transport, outdoor workers, and their different experiences of working through the pandemic, plus the lived experience of the pandemic in the various reports, both in the worker report and also in the lived experience report of COVID-19. Next slide. So before we get to applications and solutions, again, the main takeaway is that this is systemic. This isn't going to be, oh, well, when everybody comes in, we're going to get them to all do yoga. I didn't find her tweet, which I thought I had saved, but early in the pandemic, there was a person who tweeted out, the same people that tell us that they're worried about our health, they're like, why don't you do yoga? But really what I need is a salary that sustains me so I don't have to constantly worry about where my next meal is going to come from, how I'm going to pay my bills, how I'm going to sustain myself. That's more of a stress. And that really stayed with me because I was like, that is exactly it. Tackling a systemic problem with only one factor is frustrating for the people on the other side, but it also doesn't solve the problem. So whilst, yes, again, I'm not saying don't do that and don't be supportive in that way, but if you're not giving people the tools and resources to live a life of dignity, then we're not doing enough. And that's the big takeaway from this, is to really see how all the elements of our lived experience and the places that we live factor into health, factor into worker health. So next slide, please. So the applications and the solutions, again, they have to be systemic then. So one of the things that we're highlighting is supporting worker rights. There are the old school worker rights, the people that have fought for them historically, which are our factory workers, our drivers, our essential workers. We have to come out and support them because it's not right for people to suffer poor health outcomes simply because of the job that they're doing. We're not living in 1855. We need to do better. But equally, there are some new regulations that should be coming in. If we are to continue working from home, then what are the regulations and what are the standards that a company has to be responsible for in terms of providing people with the right resources and comfort within that home in order for them to do their work? And also, how do we create a cleaner line between work and home when we are spending so much more time at home? By that, I mean not having the expectation that someone's going to answer your email and your phone call at 11 o'clock at night. So we are going to need to look at new worker policy and new worker rights because of COVID. Next slide, please. So internal healthcare teams. By this, again, I'm not talking about the coaches that some of these big organizations could bring in or the well-being advisors. I am talking actual clinical staff, neuropsychologists, psychologists, cognitive therapists, and perhaps even GPs, bringing them into the workforce. And again, not just for the luxury C-suite, but across the board. And not just for the corporate industry, but again, across all industries, that there's actual internal teams inside the organization where if somebody is having a panic attack, somebody is having an episode with depression, somebody that's coming back in and transitioning is dealing with PTSD, there are on-site teams that can help them throughout the day or create longer term healthcare plans. And I don't mean, sorry, healthcare as in like take these pills. I mean healthcare plan in everything from we're going to bring you in twice a week because you're not ready for 5 days. Then at this point, we're going to bring you at 5 days. These are the extra supports that we're going to give you, including a salary review. Because again, we have to understand that people are going to be coming into the work, for those who have been furloughed or lost their jobs, they're going to be coming back into the workforce with a lot of debt because of monetary loss during the pandemic. And we all know how finance relates to health and to stress. So even part of that healthcare group should be financial advice, how to get back on your feet financially. And again, I am talking from the people that are foundational workers all the way up to the C-suite. Next, please. And then we have to all work at improving the urban footprint, right? We can't advocate for health at any point, worker health, people, at a civil level, if we're not looking at cleaning up our cities and improving our cities, and all of us that work at city levels at different ways, if we're not promoting it, if we're not helping improve it. And that could be joining an advocacy group, that could be campaigning for a specific pollutant, that could, again, sorry, not for, that could be getting involved in how do we improve public transport, and that we're not just passive in terms of our communal disgust, right? That we're also active. And I think everybody on this call already has that in commonality, that we want to improve it because we can see how the malaise that we're seeing is deeply connected to the places that we live. Okay, next slide. So I'm going to stop there before I describe the exercise. Let's do 5 minutes of a Q&A, if there is a Q&A. Because I know that I just spouted a lot of words at you guys. So yeah, I'm going to pause there and for some questions.
Hey, Araceli, it's Kyle, the only other American. So I think, question I had as you were talking about some of the risk and some of the issues with, the different types of workers is, are you seeing or have you read about an increase in things like substance abuse? And obviously domestic violence has been increasing. It has a huge effect on, physiological stressors for an individual. Like, are these kind of things that we also need to be thinking of solutions for as well? Particularly, like, I know it's domestic abuse, yes, but what are you seeing on the substance abuse perspective?
Those are awesome questions. Thanks for that, Kyle. Yes, so in our lived experience report, we do talk about both.
Yeah.
And yes, that is of deep concern. That is also adding to the pathology on the domestic abuse side. It is adding to the pathology of PTSD and depression and anxiety. But equally for children, if we're talking about holistically about health, children that have suffered in witnessing the domestic abuse and perhaps also being victims of the domestic abuse, we have to also set new standards and new methods of practice, because that is a whole generation that is also going to be suffering deep trauma. And in terms of substance abuse, yes, there has been an increase in all of substance abuse. There's been an increase in suicides. There's been an increase in self-harm, in anorexia as well. And I'm pointing those out because technically they all have a similar pathology in terms of the compulsive side of it, but also in terms of coping mechanism side of it. That yes, because we've been left alone. There's been so little help in terms of mental health that that people have either entered as new into these types of disorders or have come back to them. And again, you're right, we need to think about what are those strategies to rehabilitate them properly if we want them again to participate in the workforce or as citizens.
Yeah, no, I agree. And I think with substance abuse in particular, it's like I've read a lot recently, like how the pandemic has still not disrupted like the flow of illicit substances and other things throughout the world. And it's just like it's actually just adding fuel to the fire for a lot of individuals, I think is part of the issue. And like I said, I think I've told you guys this before, but I live by myself and work from home, and it's not fun. So I'm
No.
looking forward to getting back to the office, because it does, even probably the strongest individuals, it does have quite a effect on your mental health, I think. So
Yeah, no, massively. Social isolation is another huge chunk of the malaise. We are not meant to be disconnected. Nothing in the natural world works in a disconnected way. We're all meant to be creating connections constantly, all the time. So yeah, of course, that's another pathway.
thank you.
No worries. Thanks, Kyle. Anybody else?
I have a slightly technical question
Yes, Jake.
about sharing the reports. In the actual the Urban Health Council membership website, there's like the versions of the reports almost in like web format, but is there like a shareable PDF format as well?
No, not yet.
Okay. I wasn't sure if I wasn't looking in the right area.
No, not yet. A bit of it on purpose. So I think in a couple of months after this first quarter, we're going to do the report. It was just mainly a behavioral thing that we also want people really using the website and getting used to it, working as a tool and as a library, rather than just download the report and kind of passively sit in someone's inbox. But yeah, thanks. Anyone else?
Araceli, it was just an observation, really. I was working in the private sector for maybe 25 years, or quite a long time, before moving over to the NHS last year. And it was just really an observation that the support that's available to staff in the NHS or the public sector is huge in terms of during COVID. Well, actually not just during COVID, but weekly one-to-ones with the line manager checking up on you, financial advice, wellbeing hubs, resources, work buddies who also check up on you, ergonomic checks, I mean, all sorts of things. And it was just the point that I don't think I had that once in those 25 years in the private sector. So yeah, real difference.
Oh, wow, cool. That's really good to know. I might actually ping you offline, because that might be a really nice case study, because I couldn't find a single case study for what we were describing. So I'll ping you so you can describe it to me and we can write it into the report.
Yeah, that goes alongside an acceptance of flexible working and different hours, which again wasn't really there in the private sector. So very different experience.
Wow, cool. Thanks for sharing that, Magali. Anybody else? I can't see hands, so just start shouting. Okay, cool. Everyone seems to be content to continue on. Okay, so Josh, could I have the slides again, please? So we're going to do an exercise now, and we're going to put you in different rooms, hopefully much more successfully than we did the first time when we were still trying to figure this out. I am really bad at explaining sometimes these things, so I'm going to go slow for my own benefit and not for yours. So we want to create health infrastructure. If we're going to look at things and solutions systemically, it's about creating the infrastructure for health, again, rather than single factor for health. So that's the difference. Systemic changes require infrastructure. If we're just doing single factor solutions, then you just create one solution, as it were. So we're interested in health infrastructure. You are going to be given one persona, and then you're going to be put in the room with that persona, and you're going to be divided into groups. So each group, one room, one persona. From there, you're going to choose an application or solution at a systemic level. So some of the ones that I read out, which, to just a reminder, they are the urban footprint, advocating for worker rights, and internal healthcare providers or provisions. You're going to choose which one from that persona does the best application. Then from there, you're going to choose from your toolbox, what is the best strategy for healthcare infrastructure? Does that make sense? So your persona, then you're going to pick the best solution or application for that persona, and then you're going to choose your tool of how to do it. So the tools, for example, if I remember them from memory, is campaign. So you can create a campaign that changes policy or that changes something within the built environment at a policy level, or anything else at a policy level. Then there is creating a survey, because of course we always need more information, we need more observation, so that might be your tool of choice. Or you can create a manifesto, like really push the boundaries. The manifesto is at a society, civic, civil level. Do we need just a whole overhaul of frameworks, of vocabulary, of just a new way of seeing something? That's a manifesto. Or I think the last tool is a method of practice. So a method of practice is a new set of processes and practices that need to be brought in to create health infrastructure. So that can be, as we were just saying, that can be, what does a internal healthcare system look like? It can be, what is specifically the methods of practice that we need to have to bring back someone that hasn't had a job for 6 months and has had lived through the trauma of not having a job for 6 months or a year, and everything that came specifically with COVID and that lived experience of not having a job during this year. Equally, from what Kyle just said, what's it going to be like for the worker that has been isolated for over a year working on their own? What does that transition look like? That's a method of practice. You can choose one tool, you can choose 2 tools, it doesn't matter, whatever time allows you, probably just one. And I don't know why I said choose 2 tools, sorry, that was dumb. Choose a tool is what I should have written. So again, so you choose a tool, as many as you like, or one, doesn't matter. I hope I explained that correctly. It will make more sense once you get to the mirror board. So I think Josh is going to share the mirror board with you. It's in the chat. I'm going to stop there for questions because I know I'm really dumb at explaining these types of things. So does everybody understand, or does anybody need a repeat? Okay, cool. If there's no,
I had a question actually.
Yeah.
So we're doing this on the Miro board. What
Yes.
are we writing, or how we assigned our persona? Or
Oh yeah, so good question. So Josh is going to assign you the room and the persona. And then if you guys can pick one person who is, when we come back for the 30 minutes of feedback, each group, so you're going to be divided into 3 groups. Each group has 10 minutes to present. So if you can pick one person to present back. But room and persona is going to be allocated to you.
yeah.
Hey guys. Ooh. Sorry about that. Just to follow up, yeah, I'm going to be assigning you to a particular room. Your room is going to have a name of that person, and then that name is linked on the Miro board. And then collectively as a group, you're going to decide what you're going to do there, as Ariel was saying. So that's all going to be set up for you. So you're going to be put into a room in a moment, and then that will have a name, and you just work as a team. So you may choose to do all of them in one go. So you'll have a group. I will be jumping between the rooms. Araceli is going to be fixed to one of the rooms. There's a good mix that this is automatically put together. So there's a good range of people and thinkers between the rooms. So again, it's a process to expand your mind on the whole topic. So I will crack on and open up those rooms, and we'll be jumping around to help steer if there's any questions. But hopefully most people are on the Miro board. People can see that there's the sections, there's a bio about the persona, the kind of demographic that we're looking at, so we can really investigate the questions about their lives, which Araceli has been talking about before. And then there are a bunch of post-its to the left, so any ideas that we start to form, we fill into these boxes. The room's going to be open for 20 minutes, so it's plenty of time to actually take a bit of a break, a bit of a thought, and think about the best ways to kind of create this new health infrastructure. So I hope that also answers some of the questions. I haven't received any notifications that people can't get into the Miro board. I can see there's 8 now, but I know there's more of us on the call. I know a couple people have to leave shortly. If there are any problems, then please send me a message through Zoom or email or whatever, but it should be an open access, and you should see it as the second set of graphics, the one to the right. Yeah, drop me a message and I'll speak to you guys shortly.
Okay, cool.
Actually, do you want to lead the closing session?
Sure. I mean, did everybody choose their respective speaker?
I think they did, because I sometimes chose it for them.
Okay, so Lisa's group, who is your speaker, in 5 minutes, to present.
5 minutes, 2%. What? That was me. We chose multiple. We basically split our work across campaigns, surveys, and methods of practice.
Nice.
So from a campaign, so Lisa was a mother who's got new caring responsibilities, both for her daughter and for her mother who can't work, a loss of income, crazy work hours because she doesn't want to lose her job. So from a campaign perspective, we were talking about, could we campaign for more kind of flexible working arrangements where she actually could be paid the same amount of money, but actually working less hours, and having that be sort of implemented and, I guess, focused around the flexibility and the health impacts of that. Talked about kind of stipends or employee-led or employee-paid for childcare. And then broader conversations around, what part-time actually can mean and how that works for different people's situations. From a survey perspective, we thought there's actually an ability to start with existing survey results, because there's loads of different surveys out there to kind of better frame your questions or your hypothesis. Workplace survey, or, depending on the size, we didn't know the size of the company and the kind of culture of the company. The kind of anonymous survey could work on one bookend, and the other end it could be like an intimate interview or kind of one-on-one conversation, depending on what people felt comfortable with. So that management can better understand what their employees' needs are and then make changes. Again, making sure that we're asking questions around childcare responsibilities and what that looks like, so that we can set up flexibility that works for everyone. Under methods of practice, we spoke about, we really need open acknowledgement of issues and time pressures faced by carers, and this must be discussed in a culture support them kind of working flexibly or slightly less on some days, and this needs to really be championed by leadership to show that, for example, going to appointments or taking your kid or your elderly mom to an appointment is not taboo and should be a normal thing that people are allowed to do and speak about. Simple one was kind of, she didn't have an ergonomic desk set up, so one of them was free and easy access to ergonomic working from home setup. Protocols for casual check-ins. So there was an example of the company, the teams getting together at 9 a.m. every morning for 10 minutes just to say hey, how's it going? Just to ensure a kind of sense of belonging, and trying some sort of practice to ensure people aren't working too late, or a culture that's working too late. And we also had an example of a culture where the leaders were still going into the office, and then it was driving a culture where people were going into the office just because they wanted to be seen by leaders as opposed to not actually needing to go in. So again, a big theme there on leadership, leading the charge on this in terms of doing the right things. I think that's under 5 minutes.
Cool, thank you
I
so
hope it
much,
was.
Vic. Ben, as a persona, Ben's group, who is the speaker?
Yeah. So we're going to do a joint thing here, but I'll start with the background and the solution we pick. So Ben is 50, he's on a 25 to 30K salary, he's a hospital cleaner under the foundational worker category. And he's married with 2 kids in a 2-bedroom flat, and lives with mother who used to be an essential worker, but has been sheltering in place. And so some of the main things are, his 2-hour commute to and from home, the fact that he's had COVID before, and has to purchase his own PPE for dealing with chemicals in his cleaning job. And basically, and then even though he does have the gardening and walks with his wife and everything like that, the chemicals have affected his asthma and everything like that. So he's basically got a compromised system. And so initially look like workers' rights, but what Ramsey pointed out quite well was that when you're like in this level of work and you're not like a consultant or you're not like a product manager, you're not something like that, where you have that confidence and security to kind of put a bit of pressure for your own case. It might be really intimidating for an individual cleaner to say, I want these amenities. So we actually went with a healthcare specialist team, because we think that what would be most beneficial to him is a knowledgeable authority middle person to be able to actually justify the things he needs. So we went with the specialist healthcare team for the physical and mental health and proactive interest in the health and well-being for self and family.
Yeah, and then in terms of the solution or the tool, really is we were looking at kind of a 2-pronged approach around campaigning and methods of practice. So in terms of the campaign, I think it's so often, workers like this are kind of the overlooked heroes in the pandemic. Like I know I mentioned on our session just around how grocery store workers, like without them, we wouldn't have been able to survive at the beginning of the pandemic unless everyone grew their own food. And then from a hospital worker, it's not just the frontline workers that are, help the patients. It's also everyone from the administrative function campaign on behalf of those individuals as well, to make sure they get kind of fair and equitable treatment going forward, particularly around things like having to buy your own PPE, which is just adding another stressor to his environment, and obviously being exposed to chemicals, which, in this day and age, that shouldn't be a reality, but I know it still is. So what we tried to look at is like, how do we campaign to kind of drive change from a policy point of view? And that's kind of the methods of practice. So, we're assuming this is in the UK and that there's this is the NHS. And so, we probably need a policy change to really make some, progress in terms of getting the methods of practice, initiated to help this individual. So that's why we chose the campaign, then the method of practice.
Nice. Wow. Thank you so much for that. And then from our group, Roland, would you like to go? And we had Kamir.
Sure. So Kamir was a hospitality manager, so kind of hotel manager. So 45 to 50K salary. So kind of not wealthy, but fairly stable white collar job. Lived with his husband, and then he lost his job in the pandemic. His husband suffering from long haul COVID. He wasn't able to pay the rent on his flat, so they've moved in with his parents. It doesn't say where that is, but we sort of decided that maybe that was outside of London. Very different environment, very cramped living conditions, with us putting a lot of stress on his relationship and his kind of health and well-being generally, finding it very difficult to get any sense of stability again. And obviously, you know, has to think about how he might get a new job or get his old job back or whatever. So I think we had a bit of debate about whether, what was interesting, I think, was that actually aspects of all three of those areas, supportive working rights, healthcare specialism, and advocating for better urban living, were all impinging on his situation. But it was especially difficult for a number of sort of overlaid reasons. One, that he's technically homeless, even though he maybe doesn't realize it yet. So maybe he hasn't, you know, registered as homeless, and maybe hasn't thought about that in the long term. But at the same time, there's some sort of workers' rights issues. But because he has lost his job, he is no longer a worker, and so it isn't a workers' rights. Workers' rights in his specific situation isn't necessarily going to help him directly now. So it's more like linked issues from workers' rights, including access to adequate housing, for example, as well as obviously you know, payment for redundancy and so on. Obviously, there isn't detail of that in the description. But all of those areas. So what we decided to do was to identify it as a kind of Venn diagram overlapping area of those three areas, and that, so not only about affordable housing, but also that his parents' house is now a healthcare environment, and the question about, so the suggestion of a strategy of healthcare workers into working environments doesn't tackle the issue of people now caring for people in the home environment, and how can that be facilitated. So I guess we were sort of asking more questions and coming up with answers, really. And I think we settled on a survey as being the sort of key tool, because we felt like this is the kind of tip of an iceberg in a way, and that there's probably, or there are almost certainly great numbers of people with similarly new, sudden, significant changes in their situations, and that even just understanding the scale of the problem was really important, and that because of the ongoing situation, but also the scale of the problem, it means that any solution is really in the long term. And so what we'd be trying to advocate for really is policy change. And essentially it's more about having a kind of, you know, a better safety net, more resilient policies to be able to support people in these kind of extreme scenarios. I think that about covers it, does it, Araceli?
Yes, thank you. And then I just wanted to point out also what Charlotte said in terms of the long-term, or the temporal nature of these issues, that, you know, we realized, okay, it's going to take probably way more than a year for someone like Kamir to get back on their feet, between finding a job, saving up again to move back to London, and then all of the mental processes that are going to have to ensue, that he'll have to do that with, also battling anxiety or depression, and his husband having long haul COVID. We are at time. So the only thing that I wanted to round up is that hopefully the takeaway is that we're dealing with very complex systemic issues, that all roads lead to health, and that we have to work harder than what we currently have, which is just very linear routes to health, or one factorial routes to health. That we could have those, but only if all the other systemic things are working in place. And and that coming back to a quote unquote normal is going to be varied by everybody, right? Depending on what they went through in the pandemic. And how do we do that as a society? How do we do that in individual organizations? And then how do we do that professionally in terms of what do we need to do to do our bit to support health in a systemic way and build better health infrastructure. Cool. Does anybody want to add a final say? If not, we say goodbye until next time. Josh, you want to say anything?
No, other than thank you to everyone. I know it's all a new way of working. That we're throwing big questions and ideas at people and expecting them to solve quickly. But as I said at the end of the different roundtables that we do, hopefully this is leaving some different perspectives in your mind, and that's the kind of the point of the research program is to open up a slightly different narrative on a topic that we're all looking at, so that we can think better about how we apply our solutions. So I know they seem quite confusing at first, but they will trickle through, and you'll be sitting in a meeting sometimes you're going, oh, hang on, I have an idea. And that's always what we hope to do.
I do have one question. So we were looking at some pretty real topics today with real solutions and real tools. It's like, are you trying to translate that into potentially some work that you're doing, and it's something that would be of interest to other individuals as well?
Not yet. It did dawn on me as we were putting it together, but not yet. As Josh said, it's hopefully at the moment it's just building those tools and those muscles, as it were, in thinking of this in a more systemic way. And the tools that we gave you guys today, if you want to take them and do something with them, absolutely go for it. But it is first building that up. But yes, there is nothing to say that in the long term, if we go, well, we've unearthed something that as a cohort that gets put forward, we wouldn't say no.
Yeah, just wondering, and obviously it was a great conversation as always. So.
No worries. Cool. Thanks, everyone. See you guys next time. Bye.
Thank you very much.
Bye.
Bye.
Thank you.